Bismillah, Alhamdulillah, wassalatu wassalamu ala Rasulillah. In the name of Allah, the most gracious, the most merciful. Dear colleague, thank you very much for giving me this opportunity to be among you, to share my little thoughts about specific subject. Let me know by any reaction or thumb up if the video is going okay and you can hear my voice clearly. Okay, that's very good. Thank you, Dr. Mazen. First of all, I would like to thank Dr. Mazen Domani for inviting me to this nice event, and I hope you enjoy this lecture and you benefit. The most important is not enjoyment, the most important is to benefit from this lecture. This lecture is done for science without any financial or commercial interest on this lecture, and I would like to also emphasize that most of the pictures and photos used in this lecture are not my photos. They are actually some of my colleagues and some of Dr. Lorenzo Vanini and some others from the internet and from the YouTube. So the most important thing I'm focusing is science and to deliver the information. So before we start, we give the courtesy for all those people who made these photos and the YouTube to them, not to me. The objectives: by the end of this lecture, you should be able to know some information about color, about the different tooth structures and the color, analyzing the color parameters, correlation between age and color, some light effect on the shade perception, and some anatomy of the teeth that affect the color, some few information about dental photography and shade selection, and some final tips in accurate shade selection and determination. If you see this slide, for example, here, this slide can give you all the history of the development of dental materials in one slide. We give the courtesy for Dr. Robert Allen. So you can see the patient was accepting the gold foil restoration at the left side here, you can see it, as a primary filling in his or her aesthetic area in the smiling zone. And when the amalgam was developed, the patient also was accepting a class 5 restorations in the amalgam in the anterior area, and he or she has no choice but to sit down and smile. So later on, the tooth-colored materials were introduced into dentistry, and starting from the silicate cement, the glass ionomer, the composite resin, and also the patient perception also increased at that time. So the patient is not asking anymore at that time for just only amalgam versus composite, but he's asking for an invisible restoration, for an accurate color for the composite resin, or an indirect restoration. So those are some of the problems. This is Vanini's case, Dr. Lorenzo Vanini's case. Some of the problems we face in our daily practice, I think class 3 restorations, small class, for example, small class 4 restorations, medium class 4 restorations, and even large class 4 restorations. Those are most of the aesthetic problems we face in our daily practice in the anterior and aesthetic area. The first rule I want to emphasize over here is a multichromatic results can be achieved only by multichromatic layering and good anatomy. What does that mean? The tooth is composed of many colors, not only a single color. And if you want to reproduce a natural appearance of the tooth, you have to understand the nature of the color and also use multicolors to reproduce this tooth. You will hear a lot of authors that they say you can use single enamel, single dentine, single body. Yes, you can get some acceptable results, but if you want to have a perfect results, you have to have a multichromatic layering and a good tooth anatomy. So if you see over here, this slide over here, you can see the color of the tooth is changing from a buccal to a palatal direction, and from an incisal to from a gingival to an incisal direction. You can see the highest chroma is present on the cervical part of the tooth because less enamel in this area, and as much as you go toward the incisal edge, you find the chroma decreases. So exactly, if you give somebody the picture at the top left over here, this picture, and you tell him that, can you please draw this picture for me, but you only give him a blue pen and a white pen, what will happen? What will happen? He will draw something like this picture you can see over here. Yes, it looks like the same, almost, but it's different. It is the same close enough to this picture, but it's a little different. Why? Because he didn't use the same multichromatic colors which are present in the first picture. So why enamel and dentine? We always, when we do our anterior aesthetic restorations, whether we are using a direct composite or even when we send it to the lab for ceramics, for anything, they always use an enamel and dentine. I want you to imagine the tooth as those cups over here. The more enamel you put, it's clear, becomes clear. The more dentine you put, it becomes opaque in this picture. And if you put more enamel and less dentine, it becomes like this one. And if you put more dentine and less enamel, it becomes like this one. And if you put medium dentine and medium enamel, it becomes like this one here, half opaque, half translucent. So you have to understand what is enamel and what is dentine. Now you have the composite in your clinic, but you have to understand what you put more, what you get, and what you put less, what also you get. So what is color? Let's agree that color is a phenomenon, correct? It's an optical phenomenon that happens between three tripods. What are those three tripods? The first one is the object and the eye of the viewer and the light source. So any single change, any changes that happen in one of those three tripods, for sure you are going to find some changes in the color. So if you, for example, change the object, an apple color is different from an orange color. If you change the light source, a fluorescent light, an incandescent light, an indirect sunlight, whatever, it's going to also give you a little bit some variation in the color. If you use also a different a perceiver, an eye of the viewer or something, you also can get also a different perception of the color. The enamel always has shorter waves with the white blue, and the dentine has longer waves, yellow orange. But that's not important right now. We are looking for an easy, predictable way of selecting the color. I am not intended to go in a very sophisticated way in this lecture, because my aim, my goal, that everybody can select the color in an easy and predictable way. And let's see. Before you go any further, you have to make sure that you are not one of the people who have color blindness. Some people will say it's a low percentage. Actually, 8% of the male population, they have color blindness. And 0.5% of the females, they have color blindness. Always lucky females. So what happens here? Some of the people will say, okay, we don't have color blindness, we can see color. Color blindness doesn't mean that you don't see color. Color blindness, that means that you don't see the chroma of the color. If, for example, if you have a red t-shirt and the other person has another red t-shirt and the third person has a red t-shirt, but one is light, one is dark, one is medium, for the person who has color blindness, everything for him is the same. The red and the pink for him is the same. Any red category, whether it's light or deep or something, it's the same for him. So it's very important to make sure that you are not one of those people who have color blindness. This is called a color blindness or a monochromatism. How do you do this? You go to an ophthalmologist, you go to a physician, an eye specialist, you pay $200 to get consultation. There must be an easier way. Only download from the internet the color vision test plate over here, and if you don't see the number inside this circle, you might have a color blindness. So I wish somebody was in front of me over here to test some of the males and some of the females. If somebody can tell me here what is the number he can see inside this one. Well, okay, so It is 57 in this one, and in this one, for example, if anybody can see this one here, if you cannot see the number very well inside, you might really have a little problem in color selection. And the number over here is 12, for example. Before we go any further, let's go a little bit to the history of the color selection. In 1931, Clark stated that we are not yet qualified to solve the problem of the color. In 1979, which is a recent thing, Lohmeyer stated that the selection and the determination of the color had remained stuck in the last century. So, till recent time, the color problem was like a mystery. Nobody can solve it. Preston, he reassured the dentist and he told him that the color selection can be determined using a shade guide. Everybody was happy, was thinking that, oh, finally we solved the problem. But what happened? The results were so frustrating. Why? Because the shade guide doesn't have the same enamel and dentine thickness of the tooth you are dealing with. Because the shade guide doesn't have the same multichromatic layering of the tooth you are dealing with. It's a customized shade guide. Vita shade guide was the most common at that time, relying on them entirely process. What happens? The results were so frustrating. Everything was just not correct. So Miller, he was the first one who started thinking analytically. He said that if you want to be an author, you have to understand the section of the sentence, you have to understand the paragraph, you have to understand the punctuation letters. That's exactly the same thing for the color. If you want to be a colorist and select a good color, you have also to analyze color. So he was the first one who started talking about the hue and the chroma and the value. The hue, it is the color. The chroma, it is the intensity of this color or the saturation of this color. Don't worry about those terms, everything are going to be explained later. None of them at that time was giving too much attention to the value, which is the most important. If you look at this tooth over here, the upper four over here, you can see the color of the tooth itself, it's an A3. And the restored composite over here, also it's an A3. But it doesn't look nice. Why? There must be another factors other than just the hue and the chroma. So it's not enough for us. If you look at the picture at the right side over here, the original teeth might be an A3.5. And the restored crowns over here are an A3. So only half chroma different, but why it looks not nice? There must be another factors. Maybe the anatomy, maybe something else, but there must be another factors other than the hue and the chroma. So they fed up. They said, okay, we cannot really solve the problem of the color. Let's invent some machines, and those machines can do what? Can help us in selecting the color. And I really find this very odd and weird. I'm sorry for this. How come you involve technology in something you don't really understand? You are the one who put the input inside the computer. What you will tell your computer? We don't understand the color, but please solve the problem of the color for us. So they invented the spectrophotometers and the colorimeters, very expensive machines, okay? And what happened? The results were more and more and more frustrating. More frustrating than even selecting the color with the naked eye or with the shade guide. Because you use those machines, for example, something like this, depending on measuring the wavelength reflected from the tooth over here. And what happened? You get like something like this. We call it a shade map. And then when you get this one, you send it to the lab. And then when you receive the crown, another color, something different. Because those machines, they don't have the same sensitivity and the same protocol of the color selection of the tooth you are dealing with. Because those machines, they cannot differentiate between different types of materials. For them, composite or ceramics or whatever, it's the same. They don't know. Those machines are sensitive to variations and they give a lot of errors. I used to use those machines before in Abu Dhabi and in Dubai before, and I end up that those machines are very good in everything except dentistry. You can use them for selecting anything but not dentistry. So we have really to understand what we are doing with the color, not only just relying on the technology. I'm not saying that they cannot help. They can help in selecting the basic color. But to have a multichromatic, a full color, you have to depend on your skills, and I will explain this later. So there must be a shift. What I mean by shift? The problem in selecting the color always was selecting the color good at one time, and then the next time we have a bad result. One time we have a satisfactory result, and the other time we have an unsatisfactory result. So there must be a standardization. We must really have a fixed protocol that we can guarantee how the color is going to look like before even touching the tooth with the burr. Is it possible? Yes, it is possible. So finally the secret was revealed in 2001 by the article of Dr. Lorenzo Vanini from Italy, The 5 Color Dimensions. He described and analyzed the color as the hue, chroma, value, intensives or enamel whites, incisal opalescence, tooth characteristics. Do not panic. Do not panic from those terms. I know that there are some people who know these terms, but I know that a lot, they're still not familiar with those terms. So I'm going to explain everything in details. So we can say in a small conclusion that analyzing the color plus good anatomy of the tooth can achieve an accurate and every time predictable results before starting even our restoration. So let's start with the hue. What is the hue? Hue, it is the color, basic color of the tooth. When we say green, red, yellow, blue, this is called hue. That means hue. To make it easy, there are 4 main hues in dentistry: A group, B group, C group, and D group. Before we go any further, let's agree that A group and B group are the most used hues in dentistry. C group and D group are not anymore used in dentistry. That is by Yamamoto and by Vanini. So C group and D group are not anymore used in dentistry. Why? Because they have been found that they are the same as A group and B group but darker, lower value. And since I'm going to show you later how you select the value separately, so no need to use a C group and D group in dentistry. But doctor, I bought the shade guide with 300 reals and I have the shade guide with C group and D group. Should I remove it? Yes, you can remove it from the shade guide, or you can just use it for selection of a value or something later. But we don't need C group and D group in dentistry anymore. That's good. It's a good deal. So now we have almost 50% of the problem of the hue solved. We have only A group and B group. So we buy composite, we buy ceramics, A group and B group. But let's see, can we make it more easier than that? Yes, we can. A group first, it is anything that is a red, an orange-red spectrum. A group, it's an orange-red spectrum. B group, it is a red, yellowish spectrum. So the most important part in A group, it is the reddish part, and the most important part in B group is the yellowish part. So exactly you are comparing a reddish tooth versus a yellowish tooth. Reddish is A group and yellowish is B group. But, doctor, I look at the teeth and everything looks the same. Everything looks like red and yellow at the same time. Is there any tip? Yes, there is. Actually, there is a best deal that you can get from the hue. What is it? Most of the patients, they are within A group. 85 to 90% of the patients are within A group, and only 10 to 15% of the patients are within B group. Not only that, we can solve any problem if we don't have B group with A group. So some companies, like for example Mesherium company or something, they produce composites, they don't have B group in their composite anymore. So you can rely entirely on A group. So now, the next time after this lecture, when you go buy your composite, buy A group. Because even B group, it's composed maybe more than 60% of A. So mostly you can solve anything with A group. So now I solved the problem of the hue for you. Always A. That's very good. So you will write in your paper or something that hue is always A. Very good. You can see here in this picture a reddish tooth. This is an A group. And you can see over here a yellowish tooth. This is a B group. And then C and D, we don't use them anymore in dentistry. Very good. So as you see, okay, before, when we used to have a shade tab to select the color, we used to depend on what we see. Now we can depend on statistics more. No need to see right now if the hue is A or no. You can depend on the statistics. If I told you, for example, the patient or the lactose intolerance, for example, it's 5 per 1,000. When somebody has some stomach problem or gases or something, what is the first thing you are going to think? Lactose intolerance? Of course not. You depend on statistics. Same thing for color. Here, so mostly it's an A group. This is an example of the B group over here. You see, it's a yellowish, greenish tooth. And before, long time ago, in the college, we've been told that you take 2 shade tabs and compare, is the tooth is reddish, is the tooth is yellowish. No need to do this anymore right now. Just rely on A group, unless it's very clear B yellowish, you put it, but mostly to make it easy and to not go, I want really to make a small base, and from this small base we can do a little variation. But the most important thing is right now to make the base. So take it from me right now, A group is the dominant hue, and then later when you get expert in color selection, you can go a little bit, do some variations. So we solved the problem of the hue, is always A. The second thing right now, it is the chroma. What is the chroma? Chroma, it is the saturation of the hue. But what does it mean in an easier way? If, for example, you have a glass of water, clear water, you put 1 drop of red color, the glass of water turns a little red. But if you put 5 drops of red color, it becomes more red. If you put 20 drops of red color, it becomes more and more red. So it's all red. It's all the same hue. But different saturation, that means different chromas. So this is the chroma. As you see over here, the chroma, it's more in the cervical area, and as long as we go to the incisal area, the chroma decreases. Even in the crown over here, they make the chroma, the highest chroma in the cervical area and the lowest chroma in the incisal area. But how do we select the chroma? Again, before, we used to have all the composites and all the shade guides, and we put everything on the tooth. We try one over here, and then we maybe stay for like 10, 20 minutes, and then another visit, and then to try to select the chroma. But there is an easier way to select the chroma. What is it? From the age of the patient. Usually, young patient, they have a chroma of A1 or A2. Middle-aged patient, they have a chroma of A2 or A3. And old patients, they have a chroma of A3.5 and A4. So now, it's easier. Instead of having the whole shade tab and whole composite markers, the composite markers by chance, it's a small piece of the composite. You take it, you put it on the surface of the tooth. This is called composite markers, and you cure it for 40 seconds. Instead of having all this, you look at the age of the patient. If the patient is young, so you take only A1 and A2 and put them on the surface of the tooth and cure them for 40 seconds and then see. But why you are telling us about hue and chroma? We've seen many lectures they say about hue and chroma. We need to have a practical tips for this one. When I say chroma, that means which dentine composite you will use or which dentine ceramics you will use. So chroma, it's related to the dentine. And the enamel, later, it is related to something called the value. I'm going to talk about it later. So right now, the chroma, you will select which is from the age of the patient. This chroma means which dentine composite you will use mainly. So let's say that the patient is young patient, 15, 16 years old, and then you took already A1 and A2, dentine composite, you make a small ball of them, you put them on the surface of the upper central, you cure them for 40 seconds. The one you cannot see very well, it is the correct chroma. The one you cannot see very well, it is the correct chroma. This one. Okay, so let's say that I put A1 and A2. I find, for example, A1. It is a good color. So should I take a piece of A1 dentine and put it on the surface of the cavity? No. There is a little rule. What is this rule? The rule is that the cavity, if the cavity is a large cavity, the shade plus 2 shades darker. If the cavity is medium cavity, the shade plus 1 shade darker. If the cavity is a small cavity, only the basic and single shade. Dentine composite. I'm talking about dentine. In the 3 cases, you will put the dentine and you will leave a final space for your enamel composite. That's what you should do. So let's take an example. Let's say that we find that the patient, he's a young age patient, and we found that the chroma, it is A1. After we put 2 pieces of dentine composites, we cured them for 40 seconds. The one we cannot see very well was A1. So that means we will put A1, A2, and A3. The deepest layer, it's going to be an A3, and we are going to go gradually outside and downward to till we reach an A1. So A3, A2, A1. Here, we are going to put the shade plus 1 shade darker. So A1 plus A2. And here, we are going to put only A1 here. And in the 3 cases, we will leave a space for our enamel composite or enamel ceramic to have the final layer. So now we have solved the problem of the hue, which was always A, and we have solved the problem of the chroma, which we can select it from the age of the patient. And if the young age patient, it's A1, A2, middle age patient A2, A3, old patients A3.5 or A4. And now, and we know how to apply this dentine composite according to the depth of the cavity. Now we go for the third parameter, which is the value. Value, it is the degree of lightness or darkness. Luminosity, how light the restoration or how dark the restoration. When we look at the value, we don't look at the color. We don't care here about the chroma or hue or anything. You only want to know if the tooth is light or dark or medium. In dentistry, we care only about 3 main values. The values are thousands of values, but in dentistry, we care only about 3 main values. But let's understand first the value. You look at this tooth over here, three crowns over here. You can see them very well here, 3 crowns, and those 3 crowns, it's A4, A4, A4. So A means it is the same hue. 4, 4, 4 means it is the same chroma. But look at that. This one looks dark, this one looks medium, this one looks light. Why? It is the same hue and the same chroma. Because the enamel composite or ceramic is used here is different. So even if you use the same hue and the same chroma, if you use a lighter or darker enamel, it will affect how the tooth is light or how the tooth is dark. So the value which is here is determined by which enamel you will put on the tooth. This is called the value. So same hue, same chroma, but different values due to different enamel composite used in this case. So the 3 main values in dentistry is high value, medium value, low value. That's only what I want you to care in dentistry. Yes, there are thousands of values, but those 3 only that I want you to remember. High value, medium value, low value. This one. Very good. So be careful of a missed value, because missed value can really ruin up your restoration. If you miss small chroma, no problem. Half chroma, you made a mistake, no problem. But if you miss a value like this, you put like the enamel composite or enamel ceramic is very light, you are going to really find a big difference between your restoration and between the natural teeth. So remember, the value, it means which enamel composite we will use. Now we know already which dentine composite we will use from the chroma. So now we have to know which enamel composite we will use. So if we selected the value, high value or medium value or low value, we have to know that the composites come in the enamel composites come in 2 different ways. Either they come in a very clear way, high value enamel, medium value enamel, low value enamel, or by numbers, generic enamel 1, generic enamel 2, generic enamel 3. So generic enamel 1 is low value and generic enamel 3 is high value. Or it comes universal enamel 1, universal enamel 2, universal enamel 3. Or there are some companies like 3M, for example, they name the value the same way as the chroma. They call A1 enamel, A2 enamel, A3 enamel, A3.5 enamel, like this. So what we do in this case, if we don't have 3 tubes of composites with different values, if we are using 3M, for example, we can consider A1 as high value. And we can consider A3 as medium value. And we can consider A3.5 as low value. Okay, so now I hope that you understand a little bit what is the value. Some of the tricks over here that you have to understand, that the enamel of the tooth, the enamel refractive index is 1.62. and the average refractive index of the composite and the ceramic is 1.5. And the refractive index of the glass is 1.52. That means your enamel composite, it's closer to the glass more than the tooth. So you have really to search in the market for a good enamel composite that has a refractive index closer to your enamel. And there are a lot of this in the market, but since I'm not doing any commercial thing in this lecture, so I will not mention the names. You can send me or ask me anything, but there are in the market enamel composites that are very close to the refractive index of the tooth. That's what you want to get, because you want to have a light reflection the same way that as the natural tooth. So how do we select the value? Long time ago in the college, 20 years ago, I remember that my teachers, they were telling me, you have to squint your eyes, close your eyes a little bit, and look at the tooth and see how much light is emitted from the tooth. And I can certainly tell you, 20 years I haven't seen what I've been told. It's really hard to do this. The easiest way to select the values are two ways. Either from the age of the patient also. Young patient, usually he has high value. Light tooth. You see already the kids, they have thick enamel, white enamel, light tooth. Middle-aged patient, usually they have medium value. And old patients, they have a low value because of the loss of the enamel, the attrition, the loss of enamel. So more dentine is showed, and more discoloration, more depth of dentine, so it's low value. So young patient, high value. Medium-aged patient, medium value. Old patients, low value. But there is an easier way also to select the value, because you don't want to do mistake in color. You want to guarantee the result. How? By a black and white picture. Why? Because the black and white picture doesn't lie. It will give you either white, black, dark, that's it. It will not lie. Because when you do a black and white picture, you cancel everything about the color, about the chroma, about everything. You only look to the tooth if it is bright, or if it is medium, or if it's dark. Look at this scale, for example. You can see if the tooth falls in this area, that means the tooth has high value. If the tooth falls in this area, the tooth has a medium value. If it is here, the tooth has a low value. Of course, it's very difficult to find a black tooth over here, but I mean this way, and this part, and this part. So high value, medium value, low value. So you can take a black and white picture from the beginning, or you can take a normal picture, whether by your iPhone or by your camera or whatever, and then you switch it, you turn it into a black and white, and then you can compare it to this scale, or you just can see if it is white or little light gray or dark gray to know which value. So now you find that the tooth is a high value. That means you will use a high value enamel composite. You will go, if you are using, for example, the company like Mesherium or something, and you are using generic enamel, for example, 3, or universal enamel 3, or universal enamel 1. If you are not using this one, you will just depend on your 3M, for example, composite. So you will use A1, and in this case, as a high value, and you will put it as final layer, regardless what dentine composite you put. Only you are looking at the value. High value, you will use A1. Medium value, you will use A3, and low value, you will use A3.5. So this is, for example, a picture of the shade guide. I took this shade guide, I turned it with my iPhone into a black and white. Now you can see very clear right now, this is a light tooth, it brings to the white scale, and this is a medium, and this is here a dark. You can see here, see from the light, you can see the dark area. So very easy when you do it in black and white, because the black and white picture doesn't lie. So before we go, I want to make sure that we go gradually understand, because I know that there are also some students over here in the group. So we want to make it very easy for everybody, not only for professionals. So now you know already the hue is always A, mostly A, and now you know that the chroma, you select it from the age of the patient. Young patient A1, A2, middle-aged patient A2, A3, old patients A3 or A3.5 or A4. You do the chroma. It depends on, you choose which dentine composite you use, and then you put the dentine according to the depth of the cavity. Deep cavity, the shade plus 2 shades darker, middle cavity, the shade plus 1 shade darker, and light cavity, only the single shade. And in the 3 cases, you will leave space for your enamel. composite. And this enamel composite, how you will determine it? By the use of the value. And how you select the value? Either from the age of the patient or from a black and white picture. From the age of the patient, young patient, high value, middle-aged patient, medium value, old patient is low value, and now you know which enamel composite you will use. So after that, we go something we call the intensities, and they call it sometimes the intensives, and sometimes they call it enamel whites. It doesn't matter. But if you look at the tooth over here, you will find some hypomineralized spots, white spots, present actually in most of the teeth, not necessarily in young patients. So failure to reproduce those white spots that are present on the tooth will end up having a flat restoration, not realistic, not natural. So very important that after you select all those to make the white spots here, you can see it. Sometimes it's more intense like this. This one is very intense actually. We don't see this in our daily practice. And sometimes, I remember this one is my veneers, I think. I made it in 2006 in Dubai. Sorry, at that time I was not good in photography at that time. But anyway, what I'm trying to show here is I even incorporated the white stains even in 0.5 millimeter veneer. So even I put the white stains on the veneers. So it's not an excuse that you are using a 0.3 or 0.5. Enamel whites should be represented. If you are using composite, if you are using ceramics, if you are using anything, it should be represented and it should be done in a proper way over here. The patient here, in this case, was from Sharjah, and she had white fluorosis stains, and I had to reproduce this. Anyway, what I want you to do is to understand that there are some white stains present on the teeth, and sometimes it's present as snowflakes. It doesn't matter where they are and how they are. Some doctors, like Dr. Lorenzo Vanini, for example, he tried to categorize the enamel whites, where you can find those enamel whites. So he named type 1 stains, you can find here as 2 or 3 dots in the incisal edge. Type 2 clouds, you can see it as a clouds like this here in the teeth. And type 3, it's a snowflake. It's like all everywhere in the tooth as a snowflakes here. And type 4, it's horizontal lines, as you see, horizontal lines of white. But I'm telling you one of the most important tips. Do not try to memorize this. Try only to mimic the contralateral tooth. You see where's the enamel whites and you put them. Okay, the final question comes right now. Where do we put our enamel whites and how we put it? The enamel whites, we put them after the last dentine layer and before our last enamel layer. So after we finished all the dentine, we start putting these enamel whites. What are those enamel whites, the nature, and where we find them and how to put them? The enamel whites actually are a specific white composite, a little bit opaque, and we can call it a chalky appearance. Some companies, they produce it as IM, intensive milky, for example. Sometimes they produce it as enamel whites. Sometimes, if you don't have, you can use some bleach colors from the composite, but make sure it's a little bit opaque, and you can put a very tiny. Sometimes you can use a white stains, the same one you are using for ceramics, but you use for the one for the composites. Here, it doesn't matter, but you have to make those enamel whites the same way you see it in the tooth. Remember, failure of doing those enamel whites will end up having a flat restoration, even if you choose the perfect color. You have to, now we are talking about the natural oral aesthetics, how you are doing something that resembles. We cannot really do exactly like what the God created, but we can resemble as much as we can an invisible restoration that you and the patient cannot really see it very well here. So the only tip I can say in the enamel whites is young patient usually has a milky enamel whites. It's very, very, very chalky enamel whites. And adult patients, usually they have just an opaque white or a normal enamel whites. That's the only difference. So now you have selected the hue, the chroma, the value, the enamel whites. We go to the other parameter after that, which is the opalescence. This part of the tooth, we call it the incisal halo, or this part, it exhibits and reflects characters that are different from all the other parts of the tooth. So also failure to mimic or to make this part in a proper way will end up also having a bad restoration. Because it's not like I put only dentine and enamel. No, you have to understand which parts of the tooth are different from other parts of the tooth. So this part, we call it the incisal halo, and this part, it exhibits different reaction to the light. If you see a cross section of the enamel, you can see that the enamel can make really a very unique characteristics. It can reflect, absorb, and transmit light at the same time. So you can see the enamel reflection of the light. It gives you a blue color and a red color and a little bit zone of white. Let's not get confused. I don't want to confuse you. This part of the incisal halo I was talking about, mostly in most of the cases, it exhibits a blue and red color, amber color. Red means amber, so a blue and amber color together. So mostly when you have to reproduce this part, you have to use a blue and an amber color to mimic the natural appearance of the tooth. Does it mean all they are blue and red? No. But again, remember, this lecture, I'm trying to make a guidelines, a base that you can, from then you can go and find your own way. Mostly of the cases are blue and amber. The classification of this part, which is the incisal halo, okay, according to the shape and according to the color. According to the shape, we classify it as a mamelon-like. Here, this part, you can see it's a mamelon-like. Here, I'm sorry, my hand, but here, it's a mamelon-like. Or a comb-like, like as you see, zones, small zones of a clear area or a transparent area. Window-like, like a very clear, straight part of an incisal translucency. And the classification according to the color is blue, as you see here. Now you can see it very clear, a blue color in the tooth, and this line, it's an amber. You see this amber line, the red line? So mostly in this part, if you put a blue and amber, I'm okay. I'll be happy if you do this. If you put a blue and amber, in most of the cases, you can get what you want. Okay, so now, again and again, do we suppose to remember the window-like and the comb-like and the whatever, the mamelon-like? No, again, do not try to memorize. This is only some nice effort from other doctors like Dr. Lorenzo Vanini and Sprefico and Gangliani or whatever, but the most important thing is try to mimic the contralateral tooth. You see how the incisal edge looks like and mimic it. Do not try to remember, because we are not computers. That's for the shape. And for the color, remember, if you use a blue and amber together, there's actually a blue and amber together, I think, in one carpool called OBN, for example. Or you can use any other brand. Again, do not stick yourself to a specific brand. Just understand and do it your way. So a blue and amber color here. This is, for example, another example of a blue incisal halo. You can see a blue. This is another example of a gray. This is a gray here, but do not confuse yourself. This is a very rare cases that you find the gray incisal halo. And the old ages, you can find the only amber. So the only thing I can tell you, use most of the time mix between blue and amber, except in old ages, remove the blue, just use the amber only, because as you see over here, you can see only red in this part. So now we have finished the hue and the chroma and the value and the enamel whites, and I told you how to put the enamel whites on the last dentine layer after you clear the dentine layer and before you put your final enamel layer, and then you will go for the incisal halo or the opalescence. Opalescence, it means a reflection of a blue and red color that is given by the enamel due to the enamel properties. And how you do the opalescence in relation to shape, mimic the contralateral tooth. In relation to color, use mostly blue and amber, except in very old ages you can use only amber. So now this is an example of the area where you will put your blue and amber. Where you will put them? You will put them between the mamelons of the teeth. you will put them basically on the enamel areas only, between the mamelon of the teeth, here, on the enamel. And you will put the blue and amber color. It depends on which company you will buy, it doesn't matter, but take the blue and amber color, put them between the mamelon, and then you put your final layer of enamel. You can see after that the incisal opalescence in this area. How do we see the incisal part, the incisal halo area? How do we see it? Again and again, I have to mention the history and the new technologies. Long time ago, I've been in the college, and I've been told again, you look 45 degrees to the tooth. You can see the incisal halo and the incisal edge and the translucency, and it doesn't work. You cannot see it like this by your eye. The best way to select and to see the incisal halo and the incisal area of the tooth is this way. Only increase the contrast and decrease the brightness. Any picture you take it for the patient, even this is done by my iPhone 5. Now, alhamdulillah, I have 7, but this is one was done by iPhone 5. So it was just a picture, I took it, and then I only increase the contrast and decrease the brightness. And then now you can see very clearly the incisal edge, how it is incisal edge. I downloaded this picture from the internet. I just increase the contrast, decrease the brightness, and very clear the incisal part, you can see it right now. Now you know how to mimic this part because you can see. If you cannot see, how you would mimic this part. Then we go to the final parameter of the color analysis, which is called the characteristics or characterization. What is the characterization? Anything that I didn't mention before, this is called the characterization. Anything else you see it in the tooth, crack, notch, anything, you have to mimic it in the contralateral tooth. You are doing this tooth, for example, here, you have to make this crack the same way that you see it over here. But the patient doesn't like the crack. Okay, you have to give him the choice. Either if you want a natural appearance, if you want to mimic nature, if you want an invisible restoration, I have to mimic everything I see in this one. Or if you don't like it, we can change both of them over here. So you give him a choice. But you have to tell him, if I do this one without the crack, without the characterization, I will not have the same result that you expect. Then maybe you are going to blame me later. So the tooth characterizations, again and again, some doctors, they try to, like Dr. Vanini also, try to make it simple for other practitioners. So he make it like a stains, like a crack, like whatever, but again and again and again. Do not try to memorize this. Only mimic what you see in the contralateral tooth. How do we see the characterization? Now we know already how we see the value through the black and white picture. And we know now how we see the incisal opalescence and the, not the opalescence, the incisal halo area by and increasing the contrast and decreasing the brightness. Now how do we see the characterizations? The characterizations, we can see it only and in a good way by a good photo. This is the only thing that you cannot take just a normal photo. You have to use a DSLR camera, your lingual retractor, your lingual contraster, and your check retractor. If you can see in the research over here, everything is shown. 100% of the enamel cracks were seen in the picture. 100% of the transparency using only a dual flash, twin flash. The opacity, 100%, almost everything is shown in a good picture. If you see over here the picture, you can see, I know right now because I'm taking with my iPhone here, but this picture was taken by a DSLR camera, and you can see everything. The crack, you can see the zone of opacity, the translucency. Good picture can really help you in color selection. If you are interested more in reading about pictures and the characterization, you can go to this article, Registration of Internal Morphological Characteristics of the Tooth Using Dental Photography, here. So now we have finished analyzing the color only. So everything related to color analyzing, we have done it. We will write it. Either if we are using a paper, we will write it on the paper. If we are using a computer, we will write it on the computer. It doesn't matter, but we have to understand I will write, for example, hue equal A, value equal whatever, chroma equal whatever, enamel whites, whatever. Then after that, we will go to another thing, which is the light reflection from the tooth. So now we have finished 50% or 60% of the color selection. But is that everything? No. If you look at the tooth over here, you will see the light is reflected from a specific area only on the tooth. If you look at this one over here, you will see the light is reflected from the transitional line angle only from the tooth. But in this tooth, the light is reflected everywhere from the tooth. Why? Because different anatomy of the tooth can reflect different light. So the anatomy is as much important, if it's not more important than the color selection, to have a good color and an invisible restoration. You have to make a good anatomy. You have to reflect the light the same way you see it. Look at here, for example, the light is reflected from this part of the tooth, in the middle and toward the mesial part of the tooth. Look here, the light is reflected from the transitional line angle, only one transitional line angle. It's not reflected from the other transitional line angle. So when you do your restoration here, no need to accentuate this transitional line angle here. You have to make what you see, how the light is reflected. This is the anatomy. You have to make the same anatomy of what you see. How do we do this anatomy? Always when I give my friends and my colleagues the lectures, I always don't like to leave a place for chance. Not like I will do the anatomy, I will just take the whatever the carver and I will start doing the anatomy. You have to go systematically in everything, to have a predictable results. If you don't do that, do not expect any perfect results. You will have the blame at the end. Oh, I've taken the lecture, Dr. Muhammad told me about this, but I don't have the same result. If you don't follow the steps as exactly as I've told you, do not expect the results to come in the way. So the anatomy of the tooth, you have to start in a specific way to do the anatomy of the tooth. We divide the anatomy into 3 categories: primary anatomy, secondary anatomy, and tertiary anatomy. Primary anatomy, it is the outline form of the tooth and the 2 transitional line angles. Secondary anatomy, mostly, it depends on any vertical lines and grooves on the tooth. Tertiary anatomy, it's usually any horizontal lines of the tooth. So, the primary anatomy, it is the shape of the tooth, outline. Secondary anatomy, transitional line angles. Primary anatomy is the outline form and the transitional line angles. Secondary anatomy, it is the vertical lines mostly of the tooth and the vertical grooves. Anybody knows what are those vertical grooves and lines? How many loops the tooth is formed? Okay, this is the evidence of the developmental loops. You know, when the 3 loops, they unite together, they leave an evidence of their union between them. Grooves and some elevations, those are the evidence of the developmental loops. Those are the secondary anatomy. And the tertiary anatomy is anything related to horizontal lines. They call it sometimes the tertiary anatomy. They call it the perikymata. They call it the surface texture. You can hear any different names for this one. But the tertiary anatomy, it has many theories. It's not yet sure how the tertiary anatomy was found in the tooth. But one of the theories, and the most acceptable one, that those tertiary anatomy, those horizontal lines, are the evidence of the developmental lines, incremental lines of radius. Incremental line of radius. You remember in the oral histology before, there was an enamel formation, enamel rest. Enamel formation, enamel rest. Enamel formation, enamel. The area between formation and rest, it leaves some lines, and those are the incremental line of radius. The evidence, not the incremental, the evidence of those are the tertiary anatomy. Anyway, it's not yet clear the tertiary anatomy, what is the real cause for it, but this is the most acceptable theory. So the primary anatomy, this picture, I took it also from the internet. The tooth mostly either triangular or ovoid or trapezoid here. So you have to start first with the primary anatomy. You have to make the outline first. Do not go directly to the transitional line angles or to the secondary anatomy or the tertiary anatomy. First, give the tooth first the outline that really deserves. Mimic the contralateral tooth. Is the tooth triangular? Is the tooth ovoid? Is the tooth trapezoid? Then the secondary, still we are in the primary anatomy, the transitional line angles. Everywhere I go, I find even the most expert doctors, they are still using pencil to make the primary anatomy, the transitional line angles. Why not? You don't have to be like a very sophisticated and very advanced at once. No problem. I found some expert 60 years old physicians and dentists, they are using the pencil to draw the transitional line angles. Then they will start with their disc or with their burr to clear and modify everything, but they will never touch the pencil. In this case, you will have an accentuation, you will have a very clear, prominent transitional line angle, and you will start, as you see here, you will start reflecting the light from this area as you do it. The secondary anatomy, as you see it over here, then after you do already your primary anatomy, your outline form, then you do your transitional line angles, then you go for the secondary anatomy. You will make the vertical grooves and lines here according to what you see it in the other tooth. This is one of the courses I took in Dubai, and I was a student in this course. It was in a very, very, very respectable Italian teacher, Dr. Paolo Miseli, and that was done with a clay. This is my case. He was teaching me how to do the secondary anatomy in this case, and you have to understand that the secondary anatomy is as important as color selection. And the tertiary anatomy is as important as the color analysis. And the primary anatomy is the same. You cannot really separate between the color selection and between the anatomy of the tooth. Actually, if you have a good anatomy and missed chroma, nothing will be shown. But if you have a perfect color and bad anatomy, of course it will be not good. This is the case of my friend Mohamed Ali. I think most of us, we know him in the Facebook. It was done by soap, this one, and he's very good. And you can see a very clear secondary anatomy is done over here. Then we go to the tertiary anatomy here. The tertiary anatomy, as you see over here, are the horizontal lines that are present. And you can see it very well. It's aligns. Sometimes it's aligns with a mix between a little bit like vertical issues. Sometimes, but mostly it's like that here. And here we call it the perikymata. Okay. How do we do these things? The primary anatomy, of course, we can do it by our plastic instrument during carving, and some with the burr. This is like has no question. The transitional line angles, how do we do them? As I told you, you can draw with your pencil, and then you can remove everything, but don't touch. I mean not remove, I mean finish everything, but do not touch the pencil area. The secondary anatomy, the vertical lines, can be done with the red ring stone in a low speed, or you can use your high speed, but use it in a low speed. Yani do not rotate it to the full. And you can use it with water or without water. For me, I prefer doing it without water at the beginning to just know where I'm working, then you can continue with water. The tertiary anatomy can be done by also the red ring stone, this one, or I am using some tip. I learned it from one of my friends that I use the enamel adjusting kit, and I use the white flame rubber. I use it without putting it in the contra angle. I hold this one in my hand and I go from right to left or left to right till I make those scratches that you can see over here, these scratches. So now you have known already how to do all the anatomy stuff of the tooth. I'm expecting now, everybody attended right now is a colorist. He knows exactly how to do this one. Let's just take a small clinical application to make sure that everybody understood what I'm talking or what I've said right now. So this is a clinical case. It's actually in the book of Vanini. And this patient, for example, it's a middle-aged patient, and he has a large class 4 restoration. So now I hope you were in front of me to ask about, for example, some questions, but I will ask and then answer myself. So this is a large class 4. Let's say that, okay, the patient is middle age, and we will start from now, from here. What is the hue for this patient? The answer is A, because always hue is A. Very good. So now we know which composite we will use. We will buy A group composite. Okay. The second thing, what information we can get from his age, middle age? We are expecting only, not yet, expecting that the chroma will be A2 or A3, and we are expecting that the value will be median value. But this is only expectation. We cannot depend on the expectation, but we only use the information from the age of the patient to have a little expectation and make our job easier. So now we are expecting the chroma, because he's a middle-aged patient, that to be an A2 or A3. Let's say we took two small pieces of dentine composite and we put them on the surface of the tooth, and then we cure them for 40 seconds. The one we cannot see very well, it is the correct chroma. So let's say that we found the chroma for this patient, for example, was A3. So that means we will use A3 and A3.5 and A4. Why? Because it's a large cavity, big cavity. If you don't have an A4, you can use a body composite, but don't right now get to this one. Just try to remember the rule right now, then later we can make another lecture with the variations of this one. But now we have to focus on the basics first. So now we selected the chroma, A3, and we know what dentine composite we will use. Now let's select the value. So you took a black and white picture. Now I want to ask you, the tooth you see right now, is it here in this white area? No. Is it here in this black and gray area? No. But this one, if you see, it's almost here. So this one is a medium value tooth. So that means the enamel composite we will use is a medium value enamel. If we have a ready enamel composite from a company that call it medium value or generic enamel 2 or universal enamel 2, we will use it. If we don't have, and we are using 3M for example, we will take A3 enamel and we will put it as the final layer, because this is our medium value enamel here. Now, after we do this one, we started the palatal enamel, we put the layering technique, and we put the 3 layers of dentine, as I told you. Now, the time you will put the enamel whites, because that's before only you will put your enamel whites. You will put it according to what you see in the contralateral tooth. Then after that, you will put the blue and amber. Here, Dr. Vanini is using the OBN, I think Opalescence Blue Natural. That's the name of this one. It's a mix between blue and amber. He put it right now between the mamelons over here. Then he puts his final layer of enamel here. Now we will go for the primary anatomy, then for the secondary anatomy, then for the tertiary anatomy, then for the finishing and polishing, and we can have such results like this. Very easy, very predictable, very systematic. The only thing you have to do is to train yourself to do it. By chance, in the lecture, it sounds big because I'm trying to explain, but in reality, it takes up to 5 minutes only from you. So, let's go for some factors that affect the shade selection. Different light sources, lipsticks, retinal fatigue, patient's demands, metamerism, etc. Always select the shade before using the rubber dam. Why? Because after you do the rubber dam, after you put the rubber dam, the tooth becomes lighter due to dehydration. Why? Because the enamel is composed of how many percentage of water? It's 4%. So from this 4% of water, there is 1% loosely bounded water that it's easily lost when you put the rubber dam. So now you can see already the tooth becomes brighter. If you selected the shade in this area, in this time, you are going to use very light composite restorations. So always select the shade before using the rubber dam. But one important tip here, after using the rubber dam, you will start putting your composite. You will find your composite is a little bit darker than the tooth. Trust your selection at the beginning. Do not change. Do not say, oh, I made a mistake. it's like a little bit darker right now. Trust your shade selection. You have selected in a good way when the tooth was hydrated. Now dehydration happened. Remain to your principles. Do not change. The light sources over here, it's very important, and the best way we can use the light is an indirect natural light, sunlight, not a direct sunlight, an indirect sunlight, or you can use just the white light in the clinic that you can have it, but never ever use your clinic yellow or fluorescent or an incandescent light. You have to use either an indirect sunlight or you can use the normal white light, which is a little bit risky also. Look at this case, for example. That is my case a long time ago, and I'm sorry, I don't like the approach maybe I did at that time in 2006. I was still, but I'm putting this one for science only, because I did 2 zirconia crown for the patients here, and maybe that was a little bit aggressive treatment, but I'm not only sharing my success. I only want to show something here that even if I have a mistake in some picture, but I want to show you some point to emphasize about the color selection. I took the picture here with a yellow light of the tooth, of the clinic. And I took the picture here with the white light. Look what happened. The color changed dramatically from an A group almost to a B group over here. So be careful. Be careful with the light source. The light source can really ruin your selection. Always use an indirect, open the window if you have, and select the color on the natural light, on the window. If your clinic is facing the window, if you are rich, you have a clinic that is facing the window and the Nile, that's very good. If you don't have, try to find some way. Some of my colleagues, they bring the patients outside the clinic to see the color. It's important to do your job with a passion, with heart. If you don't do it with passion, with heart, if you are only doing your job only systematically because I have to do this, it's not gonna work. So the light sources, the incandescent light, the fluorescent light, neither is pure. The incandescent light is higher in yellow, and the fluorescent light is higher in blue. That's why chaired light is not recommended. Anyway, what I've told you is enough. Just use an indirect light or the white light if you don't have the other choice. The metamerism. What is the metamerism? It is 2 different objects give same color under different light sources. Let's say right now, for example, a patient came to you, and this patient has a crown on upper central, and you see the patient and you see the crown is matching exactly the upper left central. So you say, oh, that's very good. Why do I strain myself in color selection? Why I just don't call the lab, the one who made the crown, and tell them, can you please make another crown for me the same color you have done? No, because what you see right now, it might be the metamerism. You might see the upper left central and the upper right central the same color because under a specific light only. If you change the light, you might see now the difference between the crown and between the tooth. If you go for a third light source, you might see another color. So be careful. That's why I always put my patient on the clinic stool, and a little bit I move the stool to see if this is really the color. If after I move him around, I see the same thing, no change, that means there is no metamerism. If I change the color, if I change the light source, and if I change the position, light direction. But if I see any changes in the color, I will know, oh, that was a metamerism. That was only a metamerism. So never ever rely on a good crown that the patient has in his mouth and say, okay, I will use this one. Always start your color selection from the beginning. The lipsticks. You can see every different lipsticks give another color for the tooth. So it's very important to remove the lipstick before you start color selection. The dental caries, the decay. If you have a dark decay over here, like in this case, that will give you a feeling that the teeth have lower value, dark. But in fact, the teeth have medium value, not a lower value. So it has always to be a good practice to remove the caries before the color selection. And at the opposite, if you have the white caries, which we call it the white spot lesions, it will give you a feeling that the teeth, they have a high value. But actually, if you look carefully, they have medium value. So always the caries should be treated before the color selection. Some tips in using the shade guide. When the shade guide comes from the company, it's always arranged according to the chroma. A1, A2, A3, A4, B1, B2 over here. If you decided to use the shade guide, which is I don't use it, but some people they like, I don't want to confine somebody to my way. I'm only opening the way and everybody will select his own way. So if you are using the shade guide, please do not use it the same way that it comes from the company, because the company arranged it according to the chroma. A1, A2, A3, A4. Use it in this arrangement. B1, A1, B2, D2, A1, etc. This is an arrangement according to the value, not according to the chroma. From the lightest one to the darkest one. Because the value is more important than the chroma. You have to mimic the correct value. Exactly. The retinal fatigue. Always limit your color selection to 5 seconds only. Then, why 5 seconds? Actually, maybe some people, they will not really agree with that, because in some books, some authors, they write 15 seconds. But 15 seconds, it's too much, because the retinal fatigue happens very fast. If you don't believe this, look at this picture over here. At the beginning, you see it's okay, it's not moving. After 5 seconds only, you start seeing everything is moving. So the retinal fatigue happens very fast. So always limit your color selection to only 5 seconds. Then after 5 seconds, what you will do? You will go home? You will leave the patient? No. After 5 seconds, you will look to a blue object. Some books, they say blue or brown, but mostly it's a blue object. Because the blue object, it intensifies the perception of yellow color again. It will make you fresh again, as if you just had a great meal and you are ready again for the color selection. So 5 seconds, you see the color. If you don't have a judgment, after 5 seconds, you will start seeing everything yellow, everything red, everything is like mixed up. So 5 seconds, then go again to a blue color, look at blue color, then return back to the patient. Here. The direction of the shade tabs. This one, actually, I got it from the YouTube, so we give the courtesy for the doctor who made this one. Unfortunately, I don't know his name, I don't remember his name, but since I'm collecting all the information about color selection, so I have to give him the courtesy for this one. So the middle part over here of the shade tab is the part we care in color selection. So if you are using the shade tab, make sure that you use the shade tab in horizontal direction, not in a vertical direction. Because you want the middle part of the shade tab to meet the tooth. The real part, we select the shade to meet the tooth. If you use the shade tab in a vertical way and you made the cervical part facing the tooth, that will give you a feeling that the shade tab is darker than the tooth. So you will go for a lighter one, but no, it's correct if you see here. So make sure you don't make it a vertical way. If you use the shade tab in a vertical way, but the incisal part is facing the tooth, it will give you a feeling that the shade tab is lighter than the tooth. So you will have a wrong judgment. So always use it in a horizontal way. If you use the shade tab in a vertical way, and the shade tab will make a shadow on the tooth that will give you a feeling that the tooth is darker. So do not use it in a vertical way. Use it always on horizontal way. So train yourself and your eyes to guess the shade. Do not rely on shade tabs, shade guide. You have to train yourself to look at the tooth and you say, I think this is an A2 basic color. And you confirm with your composite shade guide, with your something first. Then after that, you use the method. You use the shade tab, you use the composite markers. I don't use shade guide since, I think, 2001. I don't use it since the article of Dr. Lorenzo Vanini. But again, I'm giving the choice for everybody. If he will use the shade tab, some tips that you have to do it. Here, never take the shade from a photo. Take the characteristics from the photo, takes the value from the photo, take the opalescence from the how you say, the incisal halo from the photo, but do not look at the photo and say, I think this is A3, I think this is A2, I think this is, no. The photo is only something to help you. You have to rely on your naked eyes to select the photo. Who select the shade? Some people will say technician, dentist, patient, lab, whatever. No. You have to understand what tooth, what situation you are dealing with, and then at that time you will determine who will select the shade. If you are dealing with single upper central incisor, this is the most critical tooth. If you are doing a direct composite in upper central incisor, the dentist, you are the one who will select the shade. If you are using upper single central incisor and you are using it or doing it an indirect way, then the lab technician is the best one who select the shade, not you. Do not send him a paper or a photo or say, that doesn't work. We all do this. Because of the time limit, because of the time of the lab, we do this. But I'm speaking about science. I am not speaking about what we are doing. Because me, myself, I do this mistake sometimes. But I'm speaking about the correct way. If the lab technician sent you his friend, the one he sits next to him, he works in the same lab, don't accept. Only the ceramist, the one who will do the same incisor by himself, because he is the one who will see the color and he is the one who know he will put this plus this will equal this. So the actual thing is the ceramist. He is the one who should select the indirect single central incisor. If you are doing multiple teeth, like for example 10 veneers, for example in the upper area, in this case you can let the patient share with you in the color selection. Why not? Because it's not so critical, except only if you do a single tooth. If you are doing 10 veneers, 8 veneers, share it with the patient. Let him choose the color, give him your opinion, then both have a good practice. But when you do, and you give the patient the color for selection, you have to tell him one important thing, that white is against natural. The more white you go, the less translucency you get. So some patients, I remember when I used to work in Dubai before, the patients were asking me for those colors. BL1, BL2, BL3, BL4. Oh my God. Are you sure? Are you sure you're going to use this one? This is going to be like a chalky wall. The patients say, yes, okay. At the beginning, I was like fighting. No, I will not do this. This is not correct. You have to have a natural tooth. But then at the end, I give them what they want. Because the most important thing is the happiness of the patient. If he's happy, but the most important, you have to tell him. You have to inform him that the more white you go, actually if you go above A1 or B1, you cannot get really a very natural results. So the more white you go, the less naturalism you will have. So the conclusion and summary is the color determination. It's a step, mix between color analysis and between good anatomy. The color analysis through the 5 color dimensions that was invented or described by Dr. Lorenzo Vanini, and the tooth anatomy, which is, as I explained to you, in a very systematic way, primary, secondary, and tertiary anatomy. And everything is just mixed, as I told you, between a color and the light reflection, a color and the light reflection, a color and the light reflection. That's only how you can see a very good photo. And I conclude this one by saying, وَمَا أُوتِيتُم مِّنَ الْعِلْمِ إِلَّا قَلِيلًا. Of the knowledge, it's only a little that is communicated to you. So thank you very much. I hope you enjoyed the lecture, and good luck for everyone. I'm sorry I will not be able to take questions after that because I have to do something. But I hope really you enjoyed the lecture, and good luck for all the students. And I would really thank Dr. Mazen Domani, who gave me the time and the effort and the support to be among you here and share with you this small information I have. Thank you very much. You have a great day.